Hello, everyone. Thank you for joining us. Welcome to the Surveillance Advances Seminar Series' 2024 to 2025 season. This seminar series is co-hosted by the Public Health Agency of Canada and the National Collaborating Centre for Infectious Diseases, or NCCID. The title for today's seminar is the Canadian Immunization Monitoring Program, ACTIVE, or IMPACT, Surveillance of Infectious Diseases in Canadian Children. My name is Robert Sager, and I'm research staff at NCCID. I will be your moderator today, along with Chai-Yu Lin, who is a senior policy analyst at the Public Health Agency of Canada. The NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning, programs, and policies related to infectious diseases. We are incredibly pleased to be co-hosting the series with the agency. Both Chai-Yu and I are joining you today from the city of Hamilton, situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississauga peoples. This land is covered by the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee and the Anishinaabe to share and care for the resources around the Great Lakes. Today, Hamilton is home to many Indigenous peoples from across the Turtle Island. We honor the Indigenous peoples who have lived on and cared for these lands for generations. We are very grateful for the opportunity to share and call this place home. The Surveillance Advances Seminar Series has welcomed participants and presenters from coast to coast to coast since our inception in September 2023. While surveillance is the most common term used in public health to describe the process of tracking health events and determinants through the collection, analysis, and reporting of data, due to concerns over its connotations, some have suggested the use of other terms, such as public health assessment. We acknowledge that there is still an ongoing dialogue with the use of the term surveillance in public health. For the time being, without a widely accepted term in the literature, we would like to note that we use the term surveillance in the series title to refer to the assessment of and response to public health threats as a core function of the public health systems. Now, before we dive into today's seminar, there are just a few housekeeping items I would like to mention. First, a recording of the seminar and the presentation slides will be available shortly after the seminar on the NCCID website. That's nccid.ca under webcasts. Second, the chat box for participants has been disabled for this session. The hosts will use the chat box to communicate additional information with you. If you have any technical problems with Zoom during the seminar, please email us at nccid@umanitoba.ca. Finally, please send in your topic-related questions using the Q&A tab, and we will try to address as many as possible in the discussion period after the presentation. You can like any of the questions to push them up in priority. We would also like to note that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Experience for Professional Development Hours for members of the Canadian Institute of Public Health Inspectors. If you require a letter of participation for your attendance today, please look out for the survey that will be shared after the seminar. And before we begin, we would like to note that our speaker today, Dr. Jared Bullard, bring their own unique perspectives and subject matter expertise, which we are excited to hear and learn from. The Surveillance Advances Seminar Series values opportunities like this to explore diverse ideas and foster thoughtful discussion on emerging topics in public health surveillance. This being said, please keep in mind that the views and the work that Dr. Jared Bullard will be presenting are their own and do not necessarily reflect the views or initiatives of the Public Health Agency of Canada. All right, and with excitement, I would like to introduce and welcome our speaker. Today's seminar will be presented by Dr. Jared Bullard, who is a professor and section head of pediatric infectious diseases at the University of Manitoba and the former Director General of Medical and Scientific Affairs at the National Microbiology Laboratory, or NML. Dr. Bullard's research is focused on HIV, sexually transmitted and bloodborne infections, and he was instrumental in defining the infectivity of SARS-CoV-2 during the COVID pandemic. Dr. Bullard is the provincial lead investigator for IMPACT in Manitoba. And thank you so much for joining us today, Dr. Bullard. The floor is now yours.
Wonderful. Thank you, Robert. It's always exciting to come and talk to people of a similar like mind to explain different areas of my research. And so this is one of the programs that I hope you find interesting. It has to do with the Canadian Immunization Monitoring Program Active, or IMPACT. And so what I'm going to try to do today is to place it into the context of Manitoba specifically, but then a little bit outside of this province as well. Next slide, please. So there may be some conflicts here perceived. So I am an expert panel member for NAC S2BI related to my work with HIV and syphilis. I am on the AMI board as a secretary, and that might come into play when I talk about my involvement with PICNIC, which we'll do later on. I'm also the Manitoba board representative for the CPS, and so you may know that IMPACT is associated with the CPS as well. And then finally, I'm also the Central Canada representative for the Black Physicians of Canada, which really shouldn't have much impact or influence on this particular talk. Next slide, please. So what I want to do today is to talk about impact, and in particular, put it into what's been going on over the past, I'd say, 5 to 10 years, as it relates to vaccine preventable diseases, or VPDs. What we have seen is that overall, there has been a lot more hesitancy related to vaccines. And then as a result, we're also seeing fewer children who are ultimately vaccinated with a lot of the primary vaccination that they should be receiving. And so we'll talk about why that might be important, using some cases to actually illustrate that. We'll also talk about the versatility of impact, and we'll use specifically the COVID pandemic as a good illustration of how it is able to pivot quickly. And we'll also talk about the depth and the quality of the data provided by impact, because I think that that's something that may not necessarily have been as appreciated as it could be. Next slide, please. So I do think that land acknowledgements are important, and I think that they should be a little bit more personal. So I was down in Arizona for spring break with my family, and yes, I know I went to the States, but it was a long planning in advance. And so we had the luxury of going to the Grand Canyon, and so it is one of the few things I've seen where it actually lives up to the hype, along with Michelangelo's David, and in Barcelona, Femia de Grada. So if you get a chance, go look at it. The tour guide was named Jerry Leftfoot. And so Jerry Leftfoot was a very proud Navajo. And so we were talking about in Manitoba, where it's Treaty 1 territory, the traditional lands of the Cree, Oji-Cree, the Ojibwe, the Dene people, and the homeland of the Métis Nation. And he was very excited about that because he was saying, as Navajo, that name was provided by the Spanish, but they actually voted to call themselves Dene. And that led to a discussion about Dene and Athabascan language groups, of which Navajo falls into. And I was saying, well, that's interesting because the Dene that we have in Manitoba live up north. And so it was a really interesting and cool conversation to have, to talk about the link between his ancestors and the ancestors we have here in Manitoba. Next slide, please. So let's start with some cases. I am a practicing pediatric infectious disease physician. I'm actually on call right now as we speak. So if I happen to look at my phone, that's the reason. It's just to figure out if there's something urgent I have to deal with. So the first case we're going to talk about to provide context is a 6-week-old infant girl who comes in with prolonged apneas, or periods of where she's no longer breathing. And when you talk to the family about what's been going on, they describe what's a viral upper respiratory tract prodrome, so a runny nose, a little bit of a cough proceeding. They are from southern Manitoba. There are a variety of siblings at home who attend school and daycare there. But ultimately, this child is quite sick, and so ends up having to go into the PICU where they're intubated and they're given respiratory support. And we noticed they have this really high lymphocyte cell count. And so that's actually a prognostic indicator of potentially a poor outcome. And so while she was there, she actually experienced a ventilator-associated pneumonia, or VAP, with MRSA. And so that just made things worse, right? Because she had to go on to prolonged treatment, and staying in hospital was a lot longer because of it. Finally, you also know southern Manitoba is notorious for having an unimmunized population. And so this child wouldn't have qualified for being vaccinated because they were too young, but the siblings were not immunized by parental choice. Next slide. In a similar story, we're talking about a 7-year-old boy who came from northern Manitoba. So these are actual cases that I've seen. And they live on a First Nations Indigenous Reserve community. And so they arrived in the emergency department in septic shock. They were noted to have purpura, which are these big rashes that are quite specific for meningococcus. And so that was the thought at the time. And again, this child was really sick. They had to have a tube to help them breathe. They had to go on pressor support. They were in the ICU. Ultimately, they lost a number of digits related to that, as well as their left foot. And that's not unusual to see with meningococcus. And sure enough, we did isolate Neisseria meningitis from the blood. Now, this child actually had been vaccinated, specifically from meningococcal C conjugate vaccine as an infant, and did have all of the primary series up to that point. But we did find out this Neisseria isolate was serogroup W. Next slide. Well, the final case we'll talk about is a 14-year-old man who I saw just 2 months ago. And so the young man was admitted to the PICU. He had had influenza with the current strain that is circulating, H1N1. Like the others, he was intubated and he was getting better. And we were about to extubate him, but he started getting a lot worse with really high fevers. He had new infiltrates on the chest x-ray, and he required pressors to maintain his blood pressure. When we did some cultures, we found Streptococcus pyogenes, or group A strep, from the endotracheal respiratory secretions. His blood also had this particular bug. And likewise, because of what invasive group A strep can do, he was in hospital for a long time. He had to have chest tubes to drain out the fluid in his lungs and the antibiotics and complications thereof. So let's go to the next slide, please. So this is a pretty busy slide. But what I was alluding to was a couple of things. So if I can get you to press, there should be 2 arrows that are going to come up. And the second one as well. Perfect. So if you look at that, it's highlighting the vaccination rates for meningococcus as well as pertussis. And what probably should stand out to you is that the rates are not particularly good. In the past, they used to be higher, but I think what we've been observing, especially after the pandemic, was increased hesitancy and a little bit of distrust of the general public and population when it comes to vaccinations for legitimate reasons and sometimes not. Sometimes it's a matter of disinformation, misinformation that they're able to get online. And so that conversation actually becomes quite challenging to have to try to convince people to get vaccinations for their children. But I can tell you also that the best way is when one of their children has a vaccine preventable disease. That's why it's actually really important to have surveillance like IMPACT up and running so that we can monitor what's going on. Next slide, please. So what have we seen in regard to IMPACT and pertussis? You can see that this is not unusual, that we do see several of these cases every year. And so in 2023, there were 12 cases and the majority were unvaccinated. 5 would fall into the category of ineligible. When I say that, what it means is that these are infants, or usually not infants, sorry, these are children who are under 2 months of age. So these are basically neonates or very young infants who of course are even more susceptible to all the complications of pertussis. And they may also present quite differently than you would expect with the classic whooping cough. They tend to just stop breathing. In 2024, we had 30 cases as well, and a very similar story. And thus far in 2025, we have 8 cases, with 3 being unvaccinated. Next slide. When we're talking about invasive meningococcal disease, you see a little bit different, and especially in 2023, in that we had 12 cases overall, but only 2 were unvaccinated. Keep in mind that that was the end of when we were giving at 1 year of age conjugate meningococcal C vaccine. So starting in 2024 of last year, in May, we started introducing the quadrivalent. So A, C, Y, and W135 are being offered routinely to all children in Manitoba at the age of 1. In 2024, however, you can see that of the 18 cases, a significant number were not vaccinated. And again, we fell into the category of 7 who were ineligible. And in 2025, we have 6 cases, 4 of whom were unvaccinated. And again, 3 ineligible. So this actually highlights the importance of making sure that you have vaccination in the older population in general. And the slide with the table previously was demonstrating that up to age 7 or so, we're really not achieving a very high standard. Next slide. And finally, we have invasive group A strep. And so this is something that's new, relatively new to IMPACT. And so we started that in 2024, and we had 46 cases, and in 2025, 16 cases to date. I can say again, having been on call several times in the past few months, that there is significant amount of group-based strep relative to influenza. And we know that. That's not a new thing, that's historical. But to see the amount of disease and the morbidity and mortality associated with is quite significant. Next slide, please. So this is actually a helpful slide coming from Manitoba Health. And so this is public health and the communicable disease control unit there. And what you can see is that overall, Impact did manage to actually find most of these cases. And we'll talk about probably why that was achieved. We can also see that maybe in 2024, they actually had more cases than us. But then they're far behind when it comes to invasive meningococcal disease in 2025. And that's the nature of public health. Usually when you're doing your case reports and trying to catch up on retrospective data, it does take a little bit more time. And so I think that's what we're observing here. But again, you can see that we can have a variety of different ways of doing surveillance, including public health, but it might not be quite as timely as you can achieve with something like Impact. Next slide, please. You can also see group-based strep here. And so overall, when we're talking about Manitoba, in 2024, the number of cases did increase quite a bit. And so we were also seeing that the case fatality rate was significant. So somewhere between 5 to 10%. And what does that represent? Because I can say that having seen a number of these kids and young adults, it was different. So typically we give them antibiotics, we give them one penicillin, which is straightforward, clindamycin, which is a great drug for stopping toxin production, and we give them intravenous immune globulin, and usually respond very well within about 24 to 48 hours. But we were finding that whatever was happening with group-based strep was not responding in the same way. And we didn't necessarily think it was related to the antibiotics, but if we're talking about intravenous immune globulin, that has to come from the general population and blood donations. So if there was some new strain of group A strep in the population, and people hadn't really seen it, so didn't develop antibodies, that could explain potentially what we were seeing. We can also say that overall there was a little bit more virulence and severity with the hospitalizations increasing as well. Next slide, please. This just goes to reinforce that a little bit more too, that you do on occasion see these waxing and wanings with number of confirmed cases, but ultimately the jump in 2023 was quite real. The deaths can go between that 5 to 10% overall. And so we're waiting to see what 2025 brings, because we think it's going to actually be pretty significant again because of the level of our influenza A outbreak or epidemic this particular year. Next slide. So it's not just Manitoba. If you look at across the country, you can see that the rates of group A strep are actually increasing across the board. And in particular, you'll see that there's a couple of groups that are hit fairly hard. So it's those less than one, which is not unusual. You can see again, our 10 to 14-year-old are the magic group. I don't know why they don't get sick. It's pretty impressive. And then the older group as well. Next slide. One of the interesting things that we talked about relates to the different strains. And so when I was at the NML, we were going over the different data that was available. And Irene Martin and her group at NML have been doing amazing work related to the whole genome sequencing of the various strains sent to them. And so one of the things that they observed was that M1UK, which is like a hypervirulent version of group A strep, has gradually replaced the other streps that were present. And so that might be why we were seeing this more severe disease. Now, the issue was that we weren't really doing whole genome sequencing of all of the isolates up until about 2018. So the good news is that if I accomplished anything at NML, it was to potentially have all of the isolates done retrospectively as well, just to make sure that we have an accurate picture of what we were seeing going forward. But what we were seeing in Canada, and which holds true in Manitoba as well, this M1 UK variant overall was taking more precedence. Next slide, please. So this is actually quite important, because a lot of the time you'll find that when we are doing surveillance, we are using a combination of different factors. So we have epidemiological factors, which I think most of you would be familiar with. We have clinical factors as well, which I think is more related to hospital and clinical settings. And then a lot of the time, the microbiology is not necessarily engaged in the same way. And so one of the things that we were looking at doing was making sure that this whole genome sequencing data that we had related to invasive group-based strep would be able to be linked to the epidemiological and clinical information we were gathering through PICNIC. And so PICNIC is a very similar research group, which I'm a part of, run by AMI with a bunch of pediatric infectious disease doctors. And IMPACT is doing a more prospective. So going forward, what are we seeing with invasive group-based strep? And as you can imagine, if you have your clinical, epidemiological, and whole genome sequencing microbiology data all together, that's really quite powerful. You're able to draw a lot of inferences that I don't think you would necessarily be able to do otherwise. Next slide, please. So what is active surveillance versus passive surveillance? I think that Robert had mentioned that one of the things that I do for research is related to STBBIs and syphilis. And so I was part of the Canadian Pediatric Society's surveillance program on congenital syphilis. That depended on pediatricians seeing a case of potential congenital syphilis, saying they had, and then subsequently filling out a form. So it was a lot more passive. So IMPACT utilizes an active surveillance, meaning that they're actually out there looking for these cases. And so by searching the hospital records, lab records, and discharge summaries, you're able to get a lot more information overall. And part of this also relates to the nursing that we have. So we in IMPACT are utilizing research nurses. And so research assistants are very similar, but don't necessarily have the medical background. So their ability to review charts is not quite the same as what a nurse's would be. Now, as a result, it is more resource intensive, meaning that this is a lot more work than waiting for things to come passively. It is definitely more representative of what's going on, and the results ultimately are more timely. So this is happening in relatively real time. And so there are other examples. So you can see the Canadian National Vaccine Safety Surveillance Network, as well as VaxTracker in Australia. Next slide as well. So sentinel surveillance is similar in that we're hoping that we can capture a key group or population and thereby infer kind of what's going on in the entire group. And so this is what we would consider IMPACT as well. It's good because we also have standard case definitions and protocols. And if you're a researcher and you know, case definitions are kind of the rate limiting step in terms of if you have 14 different case definitions all across the country, it makes it a lot harder. The good news is that by harmonizing all of those, we have a little bit more power. Next slide, please. So this might not be true of all of the different impact sites, which we'll highlight in a few moments, but in Manitoba, over 30 years, we established a pretty extensive team with a lot of collaboration and a lot of respect for each other. And so prior to me taking over Impact 2 years ago when Joanne Embry retired, she had really done a lot of work. And so we have a dedicated research nurse who is very familiar with pediatrics. She worked in the NICU and on the wards for a very long time. And so she works quite well to go through those charts and knows how to collect the information. In the event that she's struggling, she has access to an infectious disease specialist. And that's true of all of the different centers with impact. And so that's actually really important because, as you can imagine, a person trained in infectious disease has a better understanding of vaccine preventable diseases, adverse reactions related to vaccines. I happen to have a medical microbiology background as well, so I bring the lab perspective to that. But we also have worked very hard to link with public health and the CDC here in Manitoba at Manitoba Health. And so by working together, we're able to catch additional cases that might have somehow slipped through. Because of the association with CADM Provincial Lab, which is where I work as well, we get additional information too. So very nicely, we're able to get that clinical, epidemiological, and microbiological data all together in one place. We also work with our infection prevention and control team at the Children's Hospital. So again, that's just one more layer to ensure that we really are able to get all of this. Now, keep in mind, this took 30 years to establish and refine these working relationships. And as you can see there, when you have a team consisting of public health and nursing that knows what they're doing from pediatrics perspective, infectious diseases, infection control, that's a really comprehensive team. And I think that that's actually really essential to ensure surveillance when we're talking about things like vaccine preventable diseases. Next slide, please. So we're not alone, of course. There are 14 pediatric tertiary care centers, and a variety of them are doing work with vaccine preventable diseases. And so initially, the whole goal back in 1991 was to look for serious adverse events following immunization. And that was, of course, in children. And the definition of children does change sometimes, but this is 0 to 16. And it works quite well in that we have over 90% of tertiary care pediatric beds covered, with referrals from all provinces and territories in Canada. And so if we're talking about Manitoba and some of the smaller centers, it's almost near 100% of our tertiary care beds, just by virtue of having one children's hospital. Everything comes there. And the nurse monitors are actively looking at the admissions and conditions under surveillance. They're looking at charts and vaccine records as well. Next slide. So I did mention that we started looking at adverse events related to immunization, but it grew from there. And one of the things we really want to highlight is during the COVID pandemic, because we had everything in place ready to go, it didn't take much to suddenly pivot and say, we need to answer certain key questions. So first, what does acute COVID or infection with SARS coronavirus 2 look like in children? And you'll see that there's a number of publications that came out that were quite informative for us as clinicians, but also from public health perspective. You also probably recall that some vaccines, in particular, one product was associated with myocarditis or pericarditis, and in particular in our younger adult male population, as well as some teenage adolescents as well. And so we helped define that through impact. And finally, there was also MIS-C, or multi-inflammatory syndrome in children. And so that was really important to jump on and try to define quite effectively early in the pandemic as well. Interestingly, that disappeared after, I think, the alpha strain. And finally, of course, there's vaccine preventable diseases. And so the majority of what we're looking at relates to bacterial, as well as some of the viral, so zoster, rotavirus, and RSV. Influenza and RSV, however, have moved to a separate surveillance group overall, which we can talk about if you would like. Keep in mind that certain ones are funded by industry as well. And so it's just that they engaged impact because of the capacity to be able to do this research effectively. Next slide. So you can see overall here that impact accounted for about 4% of the adverse reports in with national pass surveillance under 18 from 2005 to 2012. See, 2005 in my head is still so close, but it's 20 years away, and that's the moment I just had in my head. But greater than 50% of all serious APHEs are reportable, and we actually managed to track those down, with even higher if we're talking about neurological adverse reactions to immunization. Next slide, please. There have been a variety of publications, and I would encourage you to look at the publication list in the link provided at the bottom. We have talked about things like BCG vaccine in Indigenous First Nation infants, the benign outcome of idiopathic thrombocytic purpura, or ITP, related to the mumps, measles, rubella vaccine, a reduced risk of seizures related to acellular pertussis, as well as encephalopathy. And then, of course, there's also post-immunization rates of Guillain-Barré syndrome, which is a known complication of some different vaccines. And then, of course, there's the evaluation of the Brighton collaboration and Sears definition surveillance. And then, of course, Kawasaki disease as well following immunization. So work has been done quite significantly to highlight all of these different events, cognizant of the time too. Next slide. This is also a really interesting finding that we had related to our work in impact, is that what you're seeing here is the number of admissions related to influenza over the past 15 years or so. And then what you see is that when we were expecting a really significant influenza wave, nothing happened. And of course, this was related to all the public health interventions that were in place. And the only virus going in the community at the time was COVID. And so this was actually a really interesting finding to show. Next slide. As well, we also showed that the number of hospitalizations really went quite low as a result of all the various interventions that we were doing. And it was neat because, again, this was something that we weren't initially designed, or we weren't intending to do, but by virtue of having everything in place, it made it a lot easier. Next slide. So there are, of course, some limitations to impact, and that is only catching the tip of the iceberg when it comes to adverse events related to immunization and vaccine preventable diseases. Usually these are children and adults who have to be severely enough affected to come into hospital. And so that's why having that additional tie-in to public health is important. Sometimes immunization history can be difficult to get. And so we don't have a national immunization schedule or registry. We literally have, every province has their own, and not all of them have it centrally recorded. Manitoba, we are fortunate that we do. And information in a chart, if you've ever had the misfortune of doing a review, know that it's not complete and it really is frustrating. Case identification is dependent on local testing and admitting practices. So there might be places that don't admit at the same level as others. And it is fairly labor intensive. At 6,000 cases screened to identify about 100 to 120 reportable APHEs annually. And when COVID hit, we did have a specific issue related to the Omicron wave because a lot of what we were looking at was RSV. Because RSV, you might remember in 2022 or 2023, hit us really quite hard. So it's a lot of resources overall, but I think that the data ultimately that you're getting is worth it. Next slide, please. So with that, I think we've left enough time for a significant number of questions. I appreciate that we have people from across Canada. If you don't know who Connor Hellebuck is, I think by the end of the NHL playoffs, you're going to know. And that was my wife and I at the game last night where the Jets happened to pull ahead 2-0 against the, who are they playing even? Oh, St. Louis. I do know. But they weren't very good, so it's all good. I think we're in a good place. So anyway, happy to answer any questions you guys might have. And thank you for your attention.
Thank you so much, Dr. Barrett. Well, thank you so much for presenting the case study, the Manitoba data, and also like an overview of active, passive, and sentinel surveillance. It's also very interesting to learn about the essential function of impact and how impact contribute to the surveillance of vaccine preventable diseases. It was also very impressive to hear how impact could pivot to include COVID during the pandemic.
Hmm.
Having all 14 Canadian centers working together definitely requires a lot of coordination and effort. That setup exemplify the inclusive partnership that was advocated in Vision 2030, which was recently published by the Public Health Agency of Canada. We will now begin our discussion period. Please send in your question for Dr. Jared Bollat using the Q&A tab. You can also choose to upvote other people's questions. Everyone is welcome to participate in this conversation, and we will try our best to answer as many questions as possible, but we may not have time to get to all of them. So while we're waiting for the question to come in, Dr. Bella, I would like to start with a few questions that the team is very interested in. So how has Impact's role evolved in the recent years, particularly in responding to the emerging infectious threat and perception of vaccine portrayed on social media?
So I think that impact, the best one to talk about probably is COVID first. And so when we were looking at COVID, we had everything kind of in place to be able to answer a lot of the key questions. Like we could talk about vaccine efficacy, we could talk about adverse effects related to vaccination. And that was a little bit artificial, admittedly, too, because COVID was such a unique situation. And a lot of different people thought like, oh, this is all there is to infectious disease surveillance and adverse reactions and weights of vaccine preventable disease. But ultimately, I think that again, you have to appreciate that you're never going to see that degree of cases again, hopefully, knock on wood. I definitely don't want to see it. But it has been quite informative. And so this data from Impact feeds into the Canadian Pediatric Society. And so as a result, we have our infectious disease working groups there who know that the data is showing these increased rates of certain key disease. And I highlighted pertussis and meningococcus, and then I talked about invasive group A strep. And so they bring that forward and they use these cases and this data to do a couple of things. One is to educate clinicians to know to be on the lookout. Two, it's very, very helpful when we're talking to parents in particular about what we're observing related to seeing these diseases that we really shouldn't see to the same degree. And then also in terms of being able to lobby and advocate on behalf of children and those who should be receiving vaccines for additional resources as necessary and tools to be able to say, this is what we're doing. And so that's what I think Impact is feeding into. The other change I'd say, I guess, relates to we are not necessarily doing the viral respiratory diseases anymore. And so another research group is looking at that, and I was kind of alluding to it. And so we'll see what comes from that. It's a different group, and I can say that they don't necessarily have the same tie-in to all of those different groups that I was mentioning that are part of the collaborative work that took 30 years to establish. So it's there, and that's great. And I also would say that going forward, we're probably in a really good place to look for things like measles in particular, because Ontario, as you know, has several hundred cases at this point. And I think that the data that we get from that will be very helpful again to really tie everything together from the microbiological side and then also clinical and epidemiological. You're on mute, though.
I know you should by 2025, I should know how to unmute myself. We do have a question from our audience. Are there
Mhm.
any plans to improve immunization history taking, documentation, at participating hospital, even as a pilot study? What are some of the anticipated challenges that you can see?
I think when I look at um, clinical medicine as a whole, one of the issues is that we have a variety of different systems in place to record clinical information. So here in Manitoba, we have a combination of paper charts and a variety of different electronic patient records. And unfortunately, that makes it challenging to integrate all together in one simple uh, place to look at. Now, we're fortunate that we have the Manitoba Immunization Monitoring System, and that was put in place several years ago, where all vaccines administered to children and to adults in Manitoba are recorded centrally, and so we can actually just see this in our e-chart system. So that works out very well, but not every place has that. Not all provinces are using that. I think the challenge in particular as we go forward is that there is this distrust of vaccines. And I'd like to say it's exclusively parents and kind of patients in the general population, but that relays as well to some degree to the political level. And so you might see a bit of hesitation to be able to have the funding to be able to do that. I mean, we can look at the states and you kind of see what's going on there. And that is particularly a worry. Like if it translates to here as well, it makes it a lot harder. And then trying to get all the provinces to agree on how to best capture that vaccination data is also a problem, right? Because it's what's important to Manitoba may not be important to BC or PEI, and they might have different priorities. So that could also be a bit of a challenge. But truth be told, if we all meet and discuss, and I think that's what Impact is very good at, is to try to bring everybody together and make sure that we're all talking the same language.
Thank you. There's definitely a lot of work ahead of us. But
It's going to be a
like
lot of work.
like you say, Impact has already had a really good system that's already in place. We have another question from the audience. Given the 30-year history, what are some of the barriers and enablers to sustaining core and enhanced pediatric ID surveillance over the long term?
I think that um, what are the main challenges to that? A lot of, I think, what was established in the first 30 years um, was a slightly older generation, and not to be disrespectful at all, right? And so I don't know if there was the same appreciation for a lot of the more modern tools. And so to be able to adapt and adopt those tools might be a potential challenge. I would say that one of the other challenges that I foresee is like I'm mid-career, so I like to unfortunately admit. But when I look at who's coming down the pipe in terms of people interested in the specialty of infectious disease and microbiology and public health, we're not seeing as many people who are interested. So there might be a smaller pool as well. Um, I think one of the opportunities that we have, though, is to engage with things like artificial intelligence, right? We know that those platforms have a really unique ability to go through large sets of data and ultimately pull things out that we think are important. And so getting that and trying to understand how to best utilize that platform will be important too. And I'm not sure if that specifically answered the person's question, but I mean, the challenges are that like any institution and any group, it is hard to move away from inertia. And sometimes you have to do newer things and involve newer technologies if you can.
So to me, that seems to speak also about workforce development and also modernizing the infrastructure.
Correct. Yeah.
Thank you. So we talk during your presentation, you also talk about the timely data, reporting.
Mhm.
How can impact support timely and actionable insight for public health decision makers across all levels governments without compromising the data quality and patient privacy?
Mhm. Totally fair. So, I mean, remember that anytime we're talking about surveillance, that the data is de-identified and anonymized. So as a result, you're getting aggregate data at each provincial and Canadian level. And so you won't be able to tell specifically who people are unless you had something absurdly rare, but we don't fortunately look at that. We're looking at pretty common things when we're talking about vaccines and vaccine preventable diseases. So overall, I think that when you have that and anonymity and the aggregate data level, you're good. You're not having to worry too much about complications from that. When I'm talking about the timeliness of it, is that we have these nurse researchers who are getting this data on a weekly basis. And so it doesn't take long to enter that in, and we have weekly meetings as well to go over the data to ensure that it is sent to the central people in impact as well. So that data, because of the collaboration with Public Health Agency of Canada, is ready quite quickly. And I think that that feeds into being able to change policy as necessary. But then also, as I was kind of alluding to as well, if we know the Canadian Pediatric Society and the clinical representation is there, can also advocate on behalf and talk to government. That's helpful as well, because that's also close to real time just by virtue of being able to feed in so quickly.
Thank you. We have another question from the audience. Can the existing surveillance system reliably link early vaccine data to late evolving outcomes? So this person also provided example, maternal Hep B in pregnancy to the infant's Hep B vaccination status, to later diagnosis of the Hep B in that person where the diagnosis is probably often delayed.
Interesting question. Boy. I think that level of granularity might be challenging because you would really have to look at it. So if you're saying that you've given Hep B to a mom, right? Or Hep B vaccination to a mother, which would be a bit unusual too, that we would have to worry about Hep B vaccination in the infant. I mean, some provinces are doing Hep B vaccination admittedly in infancy, but yeah, I think overall that would be very, very challenging to link up if that infant ultimately went on to get hepatitis B and determine if the effectiveness of the vaccine in the setting of maternal vaccination or infection were at play. Yeah, that's pretty granular and complicated. So I don't know if impact would be able to answer something like that. If I'm understanding the question the way it was asked.
Well, since we're talking about like data linkage, maybe we can talk about it in the more general sense. Like, how does impact integrate with other national provincial surveillance data set? And in your opinion, what could be done to promote data linkage or interoperability?
That's a pretty high level question. And I admit that I've only been involved for 2 years as a PI here in Manitoba. So I know that because of how closely our research team works with the other members of the Manitoba team, that data is pretty easily shared for the most part. But on a national level, I would actually have to defer to some of the people who have been involved a lot longer. I'm more involved, I'd say, from the invasive group-based strep side of things. Like I am one of the co-data captains for that. And I think that we're doing a pretty good job of actually being able to share that information across the provinces and nationally as well. So unfortunately, I don't have a really good answer for that one.
Well, that's okay. Let's talk about how complex this whole system is, right?
Very, yeah.
Another question that we have is what roles do you see for impact to support the evaluation of the new vaccine in pediatric population?
Well, it's in a completely perfect place, right? So if we were to, let's say, introduce a vaccine for group A strep, and we say the example is the M1UK, we're saying the M1UK M type is becoming the predominant invasive group A strep, or most likely to cause invasive group A disease, we can then study that on many different levels. One, we can say, okay, are we seeing any adverse events related to this new vaccine being rolled out? Because each of these tertiary care centers would be able to see this. Infectious disease doctors would be able to say, is there anything that we're seeing that we didn't predict would happen related to the adverse reactions if we were to give a new vaccine? We'd also be able to tell fairly quickly that with the introduction of the new vaccine, are we seeing a reduction in the incidence of disease? And then also, more importantly, are we seeing a decrease in severe disease presentation? So impact's in a very, very good place to be able to answer those questions and quite quickly with a quick pivot. It's just a matter of getting the vaccines in place and being able to deploy them at a national level. I think that's the much bigger challenge for sure.
Thank you so much, Dr. Bullock. Oh, I don't see any more new question coming in, so I would just want to say thank. Oh, actually, just as I say that, there's another question coming in. Are evolving surveillance data available from impact for users, such as informing disease epidemiologists to support NACI's recommendation, or to vaccine industry to prioritize vaccine development?
Excellent question as well. I think what you have to appreciate that the pediatric infectious disease community in Canada is kind of small. And so that we all know each other extremely well. I think we're all fairly versed in the impact and picnic data, and a number of us sit on NACI. I'm not one of them, but I know a number of people who are. And so I can tell you that the information that they get through impact directly impacts what comes through NACI, and that sometimes, like you probably saw early in the presentation, that there is industry support for certain things like rotavirus. And so they're able to also look at this information and be able to develop better products as necessary. So it definitely does. And again, that's just the really one of the cool aspects of impact,
Hmm,
having this group of pediatric ID doctors who work together.
for sure. Thank you so much. So that concludes our discussion period for today, and I'm now going to pass it back to my co-moderator, Robert. Thank you.
Thank you.
Hello, I would like to take a moment to thank all of you for joining us for today's seminar of Surveillance Advances, and to our speaker, Dr. Jared Bullard, for presenting on impact. A reminder that the recording for today's seminar and the presentation material will be accessible for viewing on NCCID's website in a few weeks. Also, please take some time to complete our survey for this presentation. You can scan the QR code on this slide to access the survey, or look for a link in an email that will be shared shortly. In the post-seminar survey, you will also be able to request a letter of participation for your attendance today. We would love to hear from you. The survey will take less than 5 minutes, and you can tell us what worked, what didn't work, and any other recommendations for future topics or speakers. Your feedback will help us make sessions even better. Now, our next seminar will take place on Tuesday, May 27th from 1 to 2 p.m. Eastern Time or 12 to 1 Central Time. More information will be shared on the NCCID website shortly. If you have any more questions about the Surveillance Advances seminar series, please visit our webpage at nccid.ca/Surveillance Advances Seminar Series for more information. And now that concludes today's seminar. Thank you all for joining.